Good afternoon and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us today, and we think that you will find today's program very enlightening. We are very excited about our esteemed speaker, and without further ado, I am going to turn this over to Dr. Randall Maxey, our founder and leader.
You're on mute, Dr. Maxey. There you go.
Okay, thank you very much. As I was saying, thank you very much, Dr. Neighbor Stevens and Dr. Ivan Walks, my doctor. And we do have, I think, an exciting program with one of our country's finest experts in this area. So I'm going to put my slide up before I introduce the doctor. So we all know that the CDC is on top of things that are happening with these respiratory viruses, and they put up information every week. And we know that there's a new variant that one of the things she's going to talk about. We know that all viruses, including the virus that caused COVID-19, change over time. And this has been a concern. And this is why we ask our world famous expert to join us today. Her name is Dr. Virginia Kane. And even though she is from the wonderful state of Arkansas, she now resides in the state of Indiana, near the Queen City, which is Cincinnati, Ohio, where I'm from. She is currently the director of the Marion County Public Health Department, and she is associate professor of medicine at Indiana University School of Medicine, Infectious Disease Division. She previously served as president for the American Public Health Association, the nation's oldest and largest public health organization. She received the BioCrosswords 2017 award for her work in that position in dealing with life sciences, and she's the Champion of the Year award. And my most important thing to introduce about her, she was recently elected as the president-elect of the National Medical Association, the Conscience of American Medicine. And I'm very proud to introduce and happy that she's with us, Dr. Virginia Kane, MD.
Well, thank you, Randall. Indeed, it's an honor to be on the show. You have some incredible practitioners there that are just as talented and knowledgeable about COVID. So it's always an honor and a pleasure for me to have some great dialogue. And I learn a lot from these presentations, but make no doubt about it, we're going to be challenged this season because we now have a new COVID-19 strain that has over 33 mutations that are occurring involving the Omicron strain. So what does that mean for all of us? And what are the implications for the COVID-19 vaccine? And so without further ado, I would like to see if I can pull up my presentation, but I don't want to forget, I've got some kudos here that I'm hoping that we're going to have an anniversary couple join this dialogue and discussion from Mississippi. So I've just got to check to see if they're on the program here. Yes. So I just have to shout out to Dr. Edith Rayford and her husband, an incredible set of physicians out of the wonderful state of Mississippi, and they're doing incredible things, and they are now celebrating their 33rd anniversary. And it's just a beautiful story. But the state of Mississippi is so honored to have this talented duo team providing quality services to the folks in Mississippi. And so thank you for joining us today. One of the things I've been fortunate enough is that President Biden in the White House appointed me to the CDC's federal committee that oversees everything related to infectious diseases. And so that recently happened, and that's part of this is a 15-member panel. And one of those members was Jean Morazzo. She's chief of infectious diseases at University of Alabama School of Medicine, who has been targeted to replace Anthony Fauci as head of NIH. Very smart, very bright, and a longtime friend of mine. So I'm just very grateful and honored to be placed on this federal committee regarding infectious diseases. Plus, this organization, the National Medical Association, has no idea and I want to talk about our National Medical Association and what the COVID-19 task force did for this country for Black people. That task force talked with every manufacturer of the COVID-19 vaccine to make sure we had enough African Americans and Hispanics participating in those clinical trials. Precision medicine is here to stay, and it's important. And one vaccine doesn't necessarily relegate to being effective for all, but we made sure that those standards were met before we could support any vaccine. And we asked them to do additional studies for a lot of the conditions that we face and are at higher risk, such as HIV infections, such as sickle cell disease, such as diabetes, and even including obesity. What kind of impact do we have with the COVID-19? So I'm going to tell you a little bit about the future of COVID-19 infections, but I also want to remind everyone that the first virus that really got our attention was the H1N1 virus, which occurred in 2009. And then we saw following viruses. We saw the Ebola virus in 2014. We saw West Nile virus that caused an encephalitis. We saw the Zika virus that resulted from mosquitoes, but was causing anencephaly, newborn babies being born without heads or smaller shaped heads associated with severe psychomotor retardation. And there are other hosts of viruses, but I'm telling you now, whether it's through culture, climate, the conditions that are changing in this universe, we are now going to be facing future viruses, other bacteria that's going to have major ramifications for this entire world. Next slide. So this new strain of COVID-19 was identified almost about actually 2 weeks ago. The strain is called the BA 2.86. And actually it's now determined that it has 36 mutations on the strain that we call the Omicron strain. And for you to get a feel and what the significance of this is, remember when we first heard about the Delta virus and the Delta strain, and it caused so many cases, but it underwent about 30 or more mutations on that Delta virus strain, resulting in the Omicron new strain. And we went from thousands of cases related to the Delta to hundreds of thousand cases related to the Omicron strain. And so right now, we're very concerned that with these many mutations, will this result in a transformation like we saw from Delta to the Omicron? Will we see that same evidence of severity going from the Omicron strain to this new strain? Right now, it's too early to say. There's no evidence of causing more severe illness right now, but we really don't know the answer. We're probably going to have to wait till we see a whole host of more cases, probably having some better idea around probably late October or November. Next slide. What is happening right now? We're seeing an average about 1,800 people are being hospitalized daily with COVID-19. And what's happening across, I think, the country. Late July, August the 1st, we were experiencing about 12 to 13 new cases a day. This past August the 1st. We are now up to 60 cases averaging a day. So we have more than tripled the number of cases since August. And we're seeing a similar pattern across the country. And don't forget, August a lot of times is the time where a lot of people are traveling. Kids, college students are returning to school. And so we're going to start to see more transmission of COVID-19. And what makes COVID-19 so dangerous? That we can have a significant number of patients who are asymptomatic, have no symptoms. So they can spread that infection just talking to each other. Greater than 15 minutes within 6 feet can transmit that infection. Now, what's the predictions for 2023? Well, we might actually see a decrease depending on how effective people are getting vaccinated so that we could go down to 1,100 daily. But most likely, we're going to start to see, as we get into our winter months, as many as 7,500 new cases per day. So that's a concern. And we've already seen daily hospital admissions will probably be between 2,000 and 4,000 people as early as September the 18th. Right now, just 1,800 are hospitalized daily. That could be up to almost double by September the 18th. And that's less than 3 weeks away. Next slide. So where has this variant been detected? Well, 4 cases have been identified in Denmark, 2 in South Africa, 3 are in the United States, identified in Michigan, Virginia, and Ohio. 1 is in Israel, and 1 is in the United Kingdom. But here's the problem. We're not doing the genetic sequencing like we were doing at the height of the COVID-19 infection. So we will probably see lots of these cases before they're detected spreading throughout the states unknowingly. Next slide. So I'll stop there, and I think we'll open it up, if we don't mind, to questions and answers. And I want to say some tips before I take the questions, though. So the newest vaccine that's coming, is being manufactured, is the vaccine by the manufacturers Pfizer and Moderna, where they have developed a Pacific strain vaccine that protects you from the Omicron strain. So the original vaccines and primary series vaccines that we received did not protect us really from the Omicron strains. So they are developing those new vaccine strains, and those vaccines are scheduled to be delivered and distributed mid-September. So if you're getting a COVID-19 vaccine now, you are not getting a vaccine that will cover the Omicron strain. That's the latest strain that we have protection against, versus if you use the primary series of the first set of vaccines that were out, it doesn't cover the Omicron strains, so it's considerably less effective against COVID-19. So you're seeing, wow, a difference, maybe even like 70% effectiveness compared to if you've got this new variant strain having probably a greater than a 90% effectiveness. Because the predominant strain right now is the Omicron strain. We just don't know how quickly this new variant strain will multiply and be transmitted across the states. And so if you can, I'm recommending you try to wait and get the new vaccine. It will be out mid-September. Our target date to receive it is September the 15th, and we're hoping to start to give our vaccinations out September the 18th. Most of the local health departments that are the large ones and the state health departments will have this vaccine ready to distribute. I also have to remind you that we are now having businesses call us up. They're having the COVID cases occur in their businesses. So it is happening now. We're seeing COVID-19 in kids in schools. It is happening now. So please, if you're around anyone that looks like they're having what they call their allergy attack, the allergy symptoms are the same symptoms almost as COVID-19. So when someone says, hey, don't worry, I've just got an allergy, I need you to leave. Disperse yourself from that area. You don't want to be inhaling or breathing any of those respiratory particles just from simple talking. And ladies, you know what tips I use? You know, I'll be with somebody and they've just got to tell me everything and whatever. And I just say, oh, excuse me, I have to go to the ladies' room and don't come back. Men, I don't know what you say, but ladies, if you just excuse me, I'm so sorry about this, but I do need to find a ladies' room and make sure you don't come back. Don't even go in that area. And so wash your hands frequently, and you need to make sure you're carrying a mask with you at all times. And if you're traveling, please, if you're in an airport, on an airplane, or hey, you're crazy enough to get on a ship, wear that mask. Wear that mask. In some places are already requiring masks to be worn. We're not yet at that stage, but we're getting close to it. And there's chronic fatigue, I'm just telling you. But you may have to be concerned if you do your own grocery shopping, you know, going to the grocery store, there are lots of people, you may need to start wearing your mask.
Well, Dr. Kane, we sure appreciate this brilliant talk, and we want you to answer questions. I want to start off. First of all, thanks again. A few months ago, we were telling people, even if they had gotten vaccinated last year, we had recommended they get the bivalent vaccine. So you're saying the bivalent vaccine that we recently talked about is no longer efficacious, and that is not what we should be getting. So be clear.
So I'm telling you, there's a new vaccine that's out that's specifically against the Omicron strain. That's a new one that's going to be coming out shortly from Pfizer, as well as from Moderna for the COVID-19. That vaccine won't be available until mid-September. That's the one you want now.
Okay.
It's got more efficacy and it's directed to the Omicron strain, and that's the predominant majority strain that we are seeing now in this country.
Is there a reason that Pfizer and them are behind the curve right now, being so late with that, and it's coming back so strong?
So I just think one, you can identify a vaccine, but then you got to figure out how to do the mass production of it. And these pharmaceutical companies, they're not only providing the vaccines to our country, but they're providing vaccines to a lot of countries in Europe. And then you have the other problem is that the cost of these vaccines, and they're trying to determine to set the cost of how much a vaccine would cost commercially. And so that's another delay why we're not getting the vaccines. I don't know if they're hassling with the government officials about what that cost is. Now, we will still be able to provide free vaccine with this new vaccine to folks who cannot afford it and who have no insurance through our state and local health departments. But it is going to be commercialized, and there will be a cost for that vaccine by September.
Okay, my second question, and then I'll pass it on. And that is, will it be available to doctors' offices, to those who practice medicine, or do we have to line up at these big vaccination centers? Do you know how it's going to be distributed?
So, yes. So I know in at least a large metropolitan city like Indianapolis, we represent about 985,000 people. The goal is for us to try to sign up as many primary care providers who's willing to give this vaccine. And we will give instructions about it. We will talk about the refrigerator requirements for the vaccines. And so we want to encourage a lot of our primary care providers to provide this vaccine. Now, the retail pharmacy folks, they're going to be trying to get out there first and try to, have people come to them. But I don't know what's like in Los Angeles. I can tell you, we don't have those clinics a lot in the inner city area where our folks reside. And they're also even trying to close down those whatever many clinics they have in the Black neighborhoods. And so it's tough. So we need primary care providers, groups, fairly qualified community health centers to be able to give this vaccine. So call your local health department and they can sign you up and maybe provide you free vaccine. It's sort of like we have a vaccine for children program. We're trying to do one similar for adults. So someone doesn't have any money, no insurance, you can get that vaccine for free. But I do want to emphasize one last point real quickly. The shelf life for the Pfizer vaccine is very short. It only lasts a couple of months. The Moderna vaccine shelf life lasts over a year. So you have to look at that and make your decision that, man, I get all this vaccine, but if I can't utilize it quickly enough, I don't want to be stuck with a lot of vaccine that's going to expire. So our health department is making a decision that the majority of our vaccines are going to be with Moderna. The efficacy is just a little bit better, and it's been associated with less anaphylactic side effects compared to Pfizer. We're going to carry Pfizer because some people have already started the series and we want them to be able to continue with Pfizer, but we're going to get a smaller amount compared to Moderna.
Dr. Neighbor-Stephens?
You're on mute, Dr. Neighbor-Stephens.
Thank you, Dr. Kane, for that great overview. Honing in on the comments you ended with regarding choice of vaccine when you decide to go get it. Has there been a determination made that you can mix and match?
So yes, so you can mix and match your vaccines. and it does not appear to lower your efficacy. So you are allowed to mix and match. Yes.
I wanted to share that on Friday, it was announced that there were 2 school districts in Kentucky that are shutting down and going into virtual status because of COVID.
Wow.
So, stay tuned. And then there's a bunch of questions in chat, but one that I really wanted to highlight, which is, will Paxlovid be effective if you are unfortunate enough to become infected?
Yes, I think it will be affected. So it's really important that we be able to access that Paxlovid. And because what it does is, it's not going to prevent you from getting COVID-19, but it will significantly lower your risk for having a serious COVID-19 infection, from you progressing from a mild or moderate COVID-19 infection to severe infection, where a lot of times you may be hospitalized, but you're not going into the intensive care unit and you're not being placed on the ventilator. So a very effective drug, please take it. But you have a short window time frame in order to initiate it and start it.
Dr. Walks.
Thanks, Dr. Maxey. Dr. Kane, thank you. Clear and important and relevant as always. So appreciate you very much. A couple of things pulling from the chat. The first one is, I get a lot of points from my wife for always having the COVID home tests. So if somebody needs one, we can hand them out. Will the same COVID tests that have been on the market, Amazon or what have you, will we still continue to use those for the new strain?
So yes, so we're using it primarily for the Omicron strain. We don't know how effective it's going to be for this new strain because we haven't had enough cases in quantity large enough to know how effective it is against this newer strain. But for the Omicron strain, yes, it's very decent.
So, and one of the things that I always think about is just how do I walk through whatever it is that's going on? So if you can help me with walking through. So someone who has had their series of vaccinations and has had a booster, we know that folks can still get COVID. So if someone has had COVID within the last how long, then when should they go and get this new booster? If you had COVID a month ago, should you get the new booster September 18th, or should you wait? What's that time frame looking like?
So that time frame is whether if you've gotten your last booster, or you've either had an active COVID infection, your immunity will last 90 days, 3
Okay.
months.
Okay.
So you do not need to get another vaccine if you've had a current COVID-19 infection or you've had a booster. And we are about to go now, starting this season, to be able to recommend a COVID-19 vaccine once a year. Now, the exception will be for those folks who are immunocompromised significantly, like patients who may have sickle cell disease, patients who are kidney transplant or heart transplant, are on these immunomodulating agents. So those who are severely immunocompromised may require additional doses compared to if we just have diabetes or hypertension, the more milder infections, more milder chronic conditions, you will probably only require one.
So let me just, I went to public school. So let me just make sure I'm very clear. If you have had an active case of COVID-19 or you've had a recent booster, you need to wait 90 days from your last COVID
Yes.
or your last COVID infection
Yes.
or your last booster, and then you can get the new the new vaccine that's coming September 18th. So just
Right,
90 days.
You need to wait 90 days. So
Got
let's
it.
just say if I got infected August the 1st, the earliest I should be taking any vaccine is 3 months from August the 1st. So that's like September the 1st, October the 1st, November the 1st will be the first time you're eligible to take any vaccine.
Perfect.
Okay, so let me ask this question. There was somebody named, I saw a hand raised, maybe Dr. Walks or Dr. Neighbor-Stevens can get that person to ask their question. I have a patient that he's not immunocompromised, but he has hypercarbia because of a tracheal restriction from a previous thyroid goiter. And he has not taken the vaccine, any vaccine, because he's afraid of the potential side effects. How would you advise such a patient that has a breathing problem, but not immunocompromised?
Well, I think he's going to be at the highest risk if he gets the COVID-19, if he's got a breathing problem. Because the COVID-19, one of the places where the primary target of transmission of this virus is in the lungs and the heart. So if he already has a breathing problem and he gets a COVID-19 infection, it's only going to exacerbate his breathing problem. And we know that COVID-19, that if he does get COVID-19, that vaccine may not prevent him from getting the COVID-19, but it will ameliorate, it will lessen the severity of the virus. It will cut down on the ability of that virus to multiply in such large numbers that it can cause significant damage to his lungs.
Okay. I'd like to recognize Dr. Despani for either comment or question. Dr. Despani?
Yeah, hello. Yeah, I would probably say that everything that has been mentioned has been of the utmost benefit for people preparing for this next round of dealing with COVID. And the thing that I would probably emphasize is that what we're actually dealing with are escape mutations. This is actually why we keep having to utilize these different vaccines, because as I mentioned beforehand, the SARS coronavirus 2 is an RNA virus, and RNA viruses tend to mutate more readily than, say, DNA viruses. Another example would obviously be the influenza viruses, as we naturally know to get our influenza vaccines every year. And one thing too that probably bears mentioning is the fact that usually there is a movement to try to get our vaccinations done at the same time. So say SARS coronavirus 2 as well as influenza virus. And yeah, I mean, a study, believe it or not, came out recently that actually deduced rather it was better to get vaccinated in 2 separate arms, like say do your influenza shot in one arm and then your SARS coronavirus 2 shot in the other arm. And it was actually demonstrated empirically that it's better to actually get the 2 vaccines in the one arm, precisely because there will be more of the lymphatic drainage from that one area. So it actually is a cumulative or synergistic in that sense. So yeah, I mean, other than that, with regards to right now with the main variant, that would be XBB.1.5. And that is actually what the new vaccines will be targeting. It's specifically that variant. But right now, we're also seeing an uptick in EG.1.5, and I'm sorry, EG.5.1, and that one actually has 2-point mutations that differentiated from XBB point like 1.5. But again, the problem with the BA 2.86 is that it is kind of a a step shift, if you will, very similar to how Omicron was when it first emerged onto the scene, in as much as it actually had 30 different point mutations. And we're running the requisite studies in the scientific realm right now to deduce whether that means that it will be very flat-footed, if you will. But everything thus far is that it's no more pathogenic. And as I mentioned in one of my prior talks, sometimes having that multitude of different point mutations actually causes the variant itself to peter out, because it just gets so over mutated that it can't actually do anything. But those are the factors that I would add to this conversation thus far. So no need to panic or anything. Just go through the same rigmarole of getting your vaccines, precisely because even though people try to give this perception that the SARS coronavirus 2 pandemic is done, it's not. It's just in a better phase that has been potentiated by vaccine technology, but it's not necessarily done, and it hasn't really gone into a seasonal pattern where people can kind of know that it shouldn't be a fear here or there, but it is much better now than it was in the darkest days of the pandemic.
Thank you, Dr. Hispanic. Are there any questions in the chat for Dr. Kane? And I saw somebody with their hand raised, Dr. Walks.
Yes, Dr. Maxey. Edith Smith Rayford had raised her hand, but her question was answered by Dr. Kane. So the comprehensiveness of Dr. Kane is again apparent. So there are other questions in the chat. For example, Dr. Kane mentioned the Pfizer and Moderna vaccines.
And
so
let
there's a
me
question
just
about-
say, because I did see one chat, and so also there is going to be an updated vaccine from the Novavax vaccine as
Okay,
well.
good.
So all three will have an updated vaccine.
So there's been a lot of conversation about this RSV. How will that complicate the program? What should we do about that?
So we call it, the RSV, the triple threat is what we saw last season. We saw a significant number of not only COVID-19 cases, but we saw an increase in influenza cases, and we saw this RSV just take off the charts. But what was unique last season was we saw such a substantial number of cases in adults that we didn't see prior in the past, where it used to be primarily a newborn baby and young children infection. So we now just recently, I think about a week ago, just got approved an RSV vaccine for adults. And I think that's really critical, especially if you're going to be having a newborn baby coming to your household, and anyone with chronic conditions will be at higher risk for this RSV. And you can get 3 infections all at one time, but definitely you can get dual infections that can occur with this respiratory syncytial virus.
So could you also speak to how soon after you get the vaccination on September 19th, according to Dr. Walks, or whenever you get it, will it be effective? Does it take?
So normally it takes at least a minimum of 2 weeks before you start developing the antibodies. It may take a little bit longer, but the average is about 2 weeks to 3 weeks when you're developing the antibodies. So you won't get immediate protection, but it should start kicking in after 14 days.
Dr. Maxey, there was a question from Dr. Cutter in the chat, and Dr. Sherrod has her hand raised.
Okay, Dr. Cutter, the plastic surgeon, and then Dr. Sherrod. Thank you. Can you unmute Dr. Cutter and then Dr. Sherrod?
Hello, Dr. Williams. Nice to see you. Esteemed colleague.
Is Dr. Cutter unmuted?
I'm unmuted. Thank you very much, Dr. Maxey, and pardon me, Dr. Sherrod, because I think you had your hand up before I put my question in the chat, but I do appreciate the moment. Really appreciate the comments, very clear and so helpful. Thank you so much, Dr. Kane. As a oncology professional, as a surgical oncologist, what we've been encountering with the COVID vaccines and boosters is some complications surrounding their administration and the timing with regards to either surgery and or chemotherapy. So the nature of my question was, I don't know if this is definite or not at this point, but what are the recommendations in terms of patients who need surgery for a cancer? What should be the time frame between that booster or new vaccination? Someone hasn't gotten vaccination yet, of getting their surgery, and then the same thing with post-operatively. And the question still holds also for chemotherapy. Again, we have seen some complications, patients who have had to stop chemotherapy or who have had some wound complications, hospitalizations related to it. And so I've never really been able to get a good answer as to how we should conduct those vaccinations. Thank you.
I think it's kind of very difficult because you can get side effects and complications from the COVID-19 vaccine. And so if you're treating someone with cancer so close to that, it's difficult to distinguish, well, am I having any side effects related to the COVID-19 vaccine, or is it related to the treatment that I'm giving for the cancer? And so clearly, at least the recommendations that I make, if you can hold off on the surgery, I think they should be able to get the COVID-19 vaccine first, but you have to wait 2 to 3 weeks after they're vaccinated before you do the surgery. Now, if you don't have that luxury and you need to start the chemotherapy earlier, I don't recommend you get the vaccine while you're on the chemotherapy. You have to wait until they've completed their chemotherapy and then wait preferably actually 2 to 3 weeks afterwards before you get a COVID-19 vaccine. But if you could get it beforehand and you have feel very comfortable that if you're going to get some complications that's related, that's related to the vaccine, you have better protection if you're able to get the vaccine before the surgery. But if not, you need to wait, especially during the chemotherapy. And the other thing, and I didn't mention this, the Paxlovid, it's associated with a lot of drug interactions. And they have so many drug interactions that you got to look at that very carefully if you ever use that particular drug to prevent a mild or moderate infection from becoming severe.
Oh, thank you so much. Are there any other questions we have?
Dr. Sharad.
Yeah. Thanks again, Dr. Kane, for sharing all this important information. My question is concerning the pediatric population, of course, and I'm just trying to figure out how all of these new versions of the vaccines are going to accommodate the pediatric population. I haven't really had a chance to stay on top of this and do the research, but I was told that the COVID vaccine was being put into the childhood immunization schedule. And so I'm wondering if that is the case, which vaccine are they putting into the schedule? And now that we have the new vaccines coming out, I mean, it's very complicated, it seems to be, but what is your take on the pediatric population and COVID-19 vaccine?
So that's a little bit harder for me because I'm honestly, Jesse, I'm not a pediatrician, so I focus a little bit more on the adults. So I'm a little hesitant to be able to answer that question. So I don't know what to say related to that, to be honest. And we're going to run into this other problem, and people may be a little bit upset with me. We're giving so much vaccine now that's taking place in order to safeguard people. How does that impact their long-term immunity?
Yeah.
And we stimulate too much of the immune system with all these vaccines that may have some unintended long-term consequences And I'm not just sure we have enough data related to that. Now, while I say that, I feel really strongly that these kids should be getting the COVID-19 vaccine, but now we're coming back with the RSV vaccine and the others. We may need to do a
Right.
better job of spacing some of these vaccines, because becoming so close and stimulating that immune system, are we overstimulating? And it can kind of backfire on us. And I think we need to have a little bit more studies done with that. Dr. Cutter, and I want to just apologize about this. Dr. Cutter, I do want to say that if you're going to get the COVID-19 vaccine, it has to be 2 weeks before you have the surgery. But if they start the chemotherapy, like if you've got hematopoietic chemotherapy, technically they want you not to give the COVID-19 vaccine until at least 3 months after chemotherapy, because you can have longer term complications from chemotherapy. So 3 months afterwards, if you have to start the chemotherapy, if you can't give the vaccine 2 weeks prior to the chemotherapy, then you have to wait at least 3 months afterwards. And Jesse, I'm sorry about not maybe giving you a straight or clear answer, but I just have to read about that a little bit more clear.
Yeah, it's very complicated, I think. And I think Dr. Hildreth, when he was on a few months ago, was concerned about the same thing that you're talking about in the pediatric population, but not only in the pediatric population, in the adult population. And that is, how is that going to affect the long-term immunity of the patient?
Okay.
But it's getting real complicated out there now with
Dr. Bean on?
she's not on. But Dr. Neighbor Stevens, do you have any information on that at all? I know you're practicing still, right?
No, I'm not practicing, but I have to keep up with everything in my role at my company. And I am monitoring this as closely as I can. There's just not enough data yet.
Yeah.
Is there anybody from Fort Lauderdale who has a question or comment related to Simon?
While you're doing that, Dr. Cutter, I'm going to get back to you one more time. The reason why you can't give the vaccine during the chemotherapy, you have weakened their
immune
immune system. So if you give the vaccine too soon, it's not going to be able to mount the antibodies that you like. It's going to suppress the ability to multiply and be able to build enough antibodies to be effective. That's why you have to wait till all the complications related to chemotherapy. You know, sometimes you get neutropenia and things of that nature. So that's why you have to wait at least 3 months afterwards.
You know, it's interesting. If I can just follow up, do you mind, Dr. Maxey?
Go ahead.
I just follow up. You know, it's interesting that you mentioned that. You know, what we saw with the prior vaccinations is, you know, I'm a surgeon, so I do the surgical component. So I'm taking the patient through that postoperative period, getting them ready for chemotherapy and working with the medical oncologist. The primary care physician will swoop in and say, hey, get this booster. Then all of a sudden, the patient has complications and it hampers my ability to do my postoperative and the medical oncologist's ability to get them ready for chemotherapy. So we've been talking a lot about, well, what's the appropriate timing? Do we wait 30 days after surgery and then delay chemo for 30 days so that we can be outside of this window, you know, or are there certain patients where you just forego doing it in between surgery and chemotherapy just so that they can sail through their treatment? And then, as you say, wait until 3 months after to administer. So that was that gray area that I was really focused on, is between surgery and before chemotherapy. We like that, you know, 60-day window.
Well, it's going to be I hate to say it, it's going to be the patient, the case by case. So how fast do you think that cancer is progressing and whether you've got to start the chemotherapy? And then the other thing that you know that they're weak from the chemotherapy, they can't afford to get COVID-19 while they're weak.
Exactly.
And so what's happening locally in your hospital system and in your community, transmission is low, then you can feel more comfortable not worrying
Waiting.
about waiting. But if you've got a lot of high transmission, a lot of cases coming into the hospital system, and if your hospital employees are not required to get a COVID-19 vaccine, it makes it a little bit more dicey about whether I can wait until after the chemotherapy.
Right. Thank you.
Dr. Neighbor Stevens, Dr. Walker, we have any more chat issues?
I think Dr. Kane covered this earlier with respect to Pfizer and Moderna. There's a question about whether or not Dr. Kane has a preference with the new Moderna vaccine versus the new Novavax that's coming.
So I'm more of a fan of the Moderna, but I'll be honest with you, I haven't looked at as much of the literature with the Novavax, so I can't be honest about that. I've just seen the data comparing Pfizer and Moderna. And it looks like the antibody buildup is just a little bit higher and stronger and lasting just a little bit longer with Moderna compared to Pfizer. But I've not seen the Novavax compared to all three against Moderna and against Pfizer. And so
Thank you, Dr. Kane. And then Dr. Rhonda Johnson had a question with respect to the BA.2.86 variant. Is it part of the Omicron family, or is it another variant family?
So
like
it's
the
gonna
Delta?
end up being another variant family.
Okay.
And so like you had the Delta strain, you had the Omicron strain. This looks like it's going to end up being another strain after the Omicron strain.
Thank you.
Any comments from Dr. Gibson or Dr. Motley?
I do want to say this, you know, you guys had a famous basketball player's son collapse because of a congenital heart defect. And so, you know, we were always looking at the impact of myocarditis. Dr. Williams, listen to me now, myocarditis associated with the COVID-19 vaccine. And we know that the risk of myocarditis is much, much lower related to the COVID-19 vaccines compared to myocarditis as a result of getting the COVID-19 vaccine. So it's so important, especially in our young adults, to get the COVID-19 vaccine. But it highlights we have got to do more community screening for valvular heart disease starting early and not wait until someone is in their late 50s and 60s. We got to start with these kids checking for valvular heart disease, honestly, in middle school and definitely high school.
Are you saying we should do screening with what 2D echoes that early?
So I think you got to do screenings for valvular heart disease, definitely in the high schools and maybe preferably in middle schools in order to identify these valvular heart conditions. My sister had a congenital heart condition. She was told it was benign, so they did recognize she had a heart murmur, and she's from Arkansas, and told she had a benign heart condition, but it wasn't a benign heart condition. And as such, she should have had surgery, and it might have prevented her from a stroke, total blindness, and kidney failure. And so, but LeBron's son could have died on that court if they did not have a defibrillator and qualified people to resuscitate him. But how many high schools don't require a defibrillator and someone trained to revive somebody. So you go in those rural areas, those rural communities, and even in large metropolitan places, it's not there.
Dr. Kane, I want to speak as a pediatrician. We are asked to do sports physicals and sign off on participation in sports every year. And I have not seen, I'm interested to hear your comments. I had not heard them say specifically what the problem was in Young James. Have
So
you
they
heard-
have, so I can only tell you, they have not given the specific name. They have only said that he has a moderate to severe congenital heart condition that can respond to surgery, and it's expected for him to be able to get back on the basketball court. So what that tells me is he doesn't have the number one most common condition in an athlete that we worry about. That's that hypertrophic cardiomyopathy. So even when you have surgery, they don't recommend that you get back on the basketball court. So he has some other condition. I don't know what it is. But
Well,
I-
the reason I opened that up is because actually the one that we worry more about is our congenital conduction defects. And that's what my concern was on both this one, on young James and the young man that had problems a couple of months ago. And those are almost impossible to screen for. But you know what? Our overall health is not where it needs to be. And I would never say we don't need to look as much as we can at the health of all our people, our young people and our old people.
So Dr. Kane, we thank you so much. Simon, can you put up my last slide? I want Dr. Kane to comment on and make any final comments he does.
Dr. Maxey, you had asked about Dr. Motley. He is unmuted now.
Okay, Dr. Motley?
Yes, Dr. Maxey. My concern in all of this is that the testing systems that we're currently using, especially the ones you buy off the shelf in the drugstores, are not adequately situated to take on any virus or any variant of the COVID strain. It's not there. So I just caution everybody, yes, use the test you can get to, but don't totally 100% rely on them, because a lot of these strains can have some strange little nuances that are not detected by these tests. Thank you.
He makes a very good point. Exactly.
Very good.
And
Simon,
Dr. Williams,
Dr. Williams has his hand, Dr. Maxey.
Dr. Richard Williams?
Yes, sir.
The Dr. Richard Williams?
You know that's why I interrupted you, right? It's the Dr. Richard Williams.
Dr. Williams, I understand you're in Delaware with Joe.
Yeah, this is Dr. Richard Allen Williams. And the reason I mentioned the Allen is because I am in Delaware, where there was a founding. Can you hear me?
Go ahead, yes.
We can hear
Anyway,
you now.
I'm in Delaware where there was a founding of a celebration back in 1814 called the Big August Quarterly, and I'm the keynote speaker for that. In fact, I gave my speech yesterday on that. It was a celebration by slaves and ex-slaves, which is the oldest celebration of Black people in the United States history. So I'm proud to be here and to celebrate this. In any event, I just wanted to make one comment that was brought up about Bronny James and the congenital heart disease situation. Very briefly, we don't have all of the information yet, and we can't speak openly or completely about that. I know the Black cardiologist at UCLA, who is his primary provider for this condition. And he is being very, very quiet, so to speak, in regards to all this for very good reasons, obviously. So we can't say anything definitively about what he does or does not have. It is rumored that he does have a congenital heart defect. We don't know what kind, if indeed that is true. And we can't really speculate on whether and when he may come back to playing basketball. Keep in mind that exactly a month before he had his episode, there was a 7-foot center at USC also who suffered the same fate and was found to have hypertrophic cardiomyopathy. He was treated and is back playing basketball now. In fact, he was on the court when Bronny James fell down. So just stay tuned for the next episode in this. We don't know all the facts yet. We can't speak definitively about it. And if anything comes across my desk regarding that, I'll certainly let the Black Health Trust know about it.
Thank you very much, Dr. Williams. And while you're on, I want to remind people that in the near future, we're going to feature you and a patient that had a cardiac transplant postpartum. And we'll be looking forward to that. Simon, can you put up my last slide? I want Dr. Kane to comment on it before she goes. It's part called preventative measures. So Dr. Kane, can you see that?
I have to unmute myself. Yes, I can.
Okay, can you comment on that and make any last comments you would like to leave with us?
I think this is really critical. Stay at home if you are sick, and know that if you get COVID-19, you're supposed to quarantine in isolation for at least 5 days. And on the 6th day, if you are negative, you can return into a work setting only if you wear a mask between the 6th and 10th day. Also know that please get tested. I was just in the drugstore this morning at a CVS pharmacy. I saw a Binax, and it looked like the test kit cost about $23.99, at least here in Indiana. But know that local and state health departments still have a significant number of free kits. So if you want to get some kits to distribute, call and see if they can give you a quantity in order to keep it in your doctor's office if you want some free test kits. And definitely that you should seek treatment if you look like you have COVID-19. We can never forget about long COVID. So people say, oh, I'll take my chances. I'm not worried about this. Long COVID is alive and well, and you can be left with chronic fatigue for months and years with a number of other symptoms of chronic headaches, chronic palpitations, joint arthralgias. And so please wear that mask. N95s now, okay? Make sure it fits over your nose and your mouth. It drives me crazy to have people cover their mouth, but they're not covering their nose. And so it looks like they're protecting others when they only cover their mouth, but they're not protecting themselves with that nose open. And also wash your hands frequently, or you can use an alcohol hand sanitizer, but it's got to be greater than 50% alcohol in order to be effective. But washing your hands with soap and water vigorously is the key. And staying away from anybody that's sick. So somebody trying to kiss you, someone's trying to drink behind you. Hey, think of a way how to prevent that from happening without offending somebody else's sensibilities.
Sammy, you put that slide down. Again, Dr. Virginia Kane, we thank you for your valuable time and valuable information. And congratulations on your new election as the titular head of the National Medical Association. Thank you so much.
Well, thank you. You know, we have two presidents here on this call with Dr. Richard Williams and yourself. So we have a cardiologist, we had a nephrologist, and now, hey, ID is coming alive. Thank you so much. And I have to thank both of you. You guys were such great mentors to me and continue to be mentors. And I just appreciate that greatly. Thank you.
Final words, Dr. Ivan Marks.
A couple of final words, and thank you, Dr. Maxey. Dr. Kane, you know we love you, we respect you, we are proud of you. There has been a consistency of excellence that you've demonstrated, and I just think it's fabulous. This presentation has been great. My comment about our subject matter today is that there was a mention very early in today's Black Health Trust about COVID fatigue. You only have COVID fatigue until you get a bad case of COVID. And suddenly you don't have COVID fatigue anymore. You can ignore a lot of the other health problems that folks have until someone tells you that you're having a stroke because of your uncontrolled whatever you have. So Black Health Trust is really about trying to uplift the health of all of us. It's really about preventive health. And so I want to encourage everyone to take all of the topics that we talk about on these Sundays and do like we say in church. Don't just read the scripture, live the scripture. But put some changes into all of our lives that keep us healthier. And the last little comment, there was something in the chat about how to get a copy of this presentation. The Black Health Trust is not only a Zoom call, it's also on YouTube. It can be found on YouTube, it's archived. And so folks are able to view what we do after the Sunday afternoon. So thanks again.
Thank you, Dr. Neighbor Stevens.
Thank you, Dr. Maxey. Thanks again to Dr. Kane for enlightening us and being a source of truth to the community, which is a real important thing, truth. And my last words are around, we encourage you to pay attention to what's going on in your local community. That means that you're going to need to listen to your local news to see what they are saying is going on. It may mean going on the website of your local health department, but we are not able to give all the information for all over the country. During these kinds of situations, it's really critical that you stay abreast of what's going on locally.
Well, thank you so much. And the advice that we have given for the past several years, wash your hands, help your immunity by eating a lot of vegetables, leafy green vegetables, take your vitamin D, and do your social distancing. This is no joke. It can be extremely discouraging to be real sick with COVID and can even be fatal. Thanks, everybody. Thank you, Simon, for your time. Have a good day, everybody.
Thank you.
Good day, everyone.